Hello, my name is Muhammad Ibrahim and I'm a first-year internal medicine resident at Mayo Clinic in Jacksonville, Florida. And today we present a 26-year-old uninsured male with a past medical history of untreated Evans syndrome complicated by autoimmune hemolytic anemia, immune thrombocytopenia status post-splenectomy in 2015, neutropenia, common variable immunodeficiency, unprovoked bilateral upper extremity deep venous thrombi on anticoagulation, diffuse plantar foot warts, and a recent history of Pseudomonas, nocardia, and Aspergillus infections roughly 6 months ago, who presented to our emergency department after a vitreous biopsy was positive for fungal elements. This patient has been struggling with a 5-month history of left eye swelling, echinosis, and conjunctival injection that ultimately led to blindness in his left eye. He had been hospitalized many times at outside hospitals before presenting to our facility, where our ophthalmologists were unsure if this was infectious endophthalmitis, retinitis, or another inflammatory condition. They had ruled out orbital cellulitis, and systemic infectious workups were negative. Our infectious disease colleagues had recommended a 2-week course of levofloxacin and cephalexin with a close 3 months follow-up with ophthalmology to further assess the patient's eyesight and symptoms. Unfortunately, the patient's symptoms worsened, resulting in an acute onset of vitreous hemorrhage that was negative for an open globe rupture. Ophthalmology recommended atropine and prednisolone eye drops, as well as intravitreal amikacin and voriconazole. Given that his left eye was now without vision and his symptoms had worsened, including increased pain and ptosis, infection control and comfort became the main focus. A vitreous biopsy was subsequently performed that showed fungal elements. The patient was hospitalized and started on IV posaconazole, followed by a left eye enucleation and initiation of IV isovuconazonium after failing multiple treatments. He then began to experience swelling and redness around the left eye a few days after the procedure, and an MRI was done that showed brain abscesses in the left inferior frontal gyrus, posterior left cingulate gyrus, and the right occipital pole. Neurosurgery deferred any intervention at the time, and infectious disease recommended a 12-month course of 200 milligrams of voriconazole twice a day, followed by chronic secondary prophylaxis. He was deemed stable and was discharged home with a new left eye implant and an antifungal regimen. This case highlights the first reported case of acute fungal endophthalmitis in an immunosuppressed patient with Evans syndrome or common variable immunodeficiency. While most endogenous cases of endophthalmitis are caused by Candida albicans and Aspergillus and Fusarium are only really ever seen in exogenous etiologies such as trauma or postoperatively, this presentation highlights a case of endogenous endophthalmitis secondary to prior Aspergillus infections. It brings attention to the necessity of properly working up these immunocompromised patients for infections early on, as their immune response may be blunted by their disease process. Delayed detection of these bacteria and fungi can lead to future catastrophic complications such as blindness in our patient. Better prognostic tools need to be evaluated and monitored, like levels of neutropenia as seen in some literature. This will not only allow us to better serve this population, but also act as an economical tool for patients like ours who may struggle with social obstacles such as finances and access to health care. Thank you so much for listening, and I hope you enjoyed.